Hi there. My name is Cassie Howard, and I am a palliative care nurse practitioner for Pathways Hospice and Palliative Care. And today I'm going to be talking to you a little bit about palliative care and hospice. And I just wanted to thank you all for letting me be a part of this year's volunteer symposium. And a little bit about my background. So my entire background is all palliative care, geriatrics, long-term care, and I have a lot of hospice background as well. I was a hospice case manager for several years, and I was a branch manager, and then I was a regional manager. And then I didn't see a whole lot of patients any longer, so I went back to school to become a nurse practitioner so that I could kind of have the best of both worlds, a little bit of leadership role and also patient care. And I have no disclosures today. And for our objectives. So by the end of the presentation today, I would like you all to be able to describe palliative care services, describe the role of members of the palliative care team, as well as the benefits of interdisciplinary and holistic care for our patients and their families, as well as identify the type of patients who would benefit from palliative care and be able to distinguish between hospice and palliative care services. And our outline for today. Today we're going to talk about what is palliative care, the members of the palliative care team, the role of the members of the palliative care team and how palliative care is delivered, patients who might be appropriate for palliative care, and we're also going to talk about hospice versus palliative care and kind of the similarities and differences of the two. Individuals receiving hospice services have a terminal prognosis or a life expectancy of 6 months or less if the disease follows the expected course. When a person is receiving hospice services, the care is typically the members of the interdisciplinary team for the hospice generally consist of a primary care physician, the hospice medical director, a hospice RN case manager, home health aides that help with personal care, social workers, chaplain and bereavement services, volunteer services, which may include pet therapy, comfort singing, specific types of volunteer services, and then massage therapy and healing touch as indicated per agency. When an individual admits to hospice, they are agreeing that they are wanting comfort and quality of life over longevity. They must forego further hospitalizations unless they discharge from the hospice or the hospitalization is unrelated to their terminal diagnosis. And hospice services are provided routinely, meaning on a scheduled basis routinely until the patient passes away or until they discharge from hospice services. Hospice staff are available 24/7. They're on call 365 days a year. And hospice services tend to be pretty highly regulated with Medicare and other payers. What is palliative care? Palliative care is specialized medical care which focuses on the relief of pain, any type of pain. So spiritual, emotional, psychosocial pain, and it also focuses on the relief of other unpleasant symptoms of a serious illness, regardless of the patient's diagnosis or stage of the disease. Palliative care can be provided alongside curative care, meaning an individual does not have to forego that aggressive hospitalization or chemotherapy or dialysis that they might have to stop in order to start hospice services. And palliative care has a goal of improving the quality of life and relieving the suffering of patients with life-threatening illnesses. Some synonyms to the word palliative. Palliative means soothing, alleviating, calmative. And in our palliative care that we provide, we want patients and their families to feel these three comforting words when they receive palliative care. So, some similarities in hospice and palliative care. Both provide patient-centered care. Both address symptom management needs pretty aggressively. Like, that is the goal, that is the purpose of each. Both offer an opportunity for meaningful family and patient discussions. Both offer interdisciplinary team involvement, and we're going to talk about the members of the team in greater detail a little bit later. Both decrease unnecessary hospitalizations, and both really, really improve family satisfaction scores. And some differences between palliative care and hospice services. Some of these I've already mentioned, and I know this is a really busy slide, but sometimes it helps to kind of line them up. So if you are ever wanting to reference something specific about hospice versus palliative, this would be a good slide to use. For hospice, hospice is a type of palliative care. It is palliative care measures without aggressive treatment, whereas palliative care, palliative measures without withholding the aggressive treatment. Hospice is paid for by Medicare Part A, and palliative care is paid for just like a normal physician visit under Medicare Part B or Medicaid. Private insurances will pay for palliative care. On hospice, people have a 6-month or less prognosis. And on palliative care, palliative is appropriate at any stage in the disease process. So palliative can actually start at the time of diagnosis of heart failure or cancer. And we'll talk about that here in a minute. People on hospice will not return to the hospital unless they revoke hospice or the hospitalization is unrelated to their terminal illness. People on palliative care may return to the hospital. On hospice, some medications, equipment, and personal care supplies are provided, and palliative care does not include any of that. So think of palliative care as like a provider visit. We are a specialist visit. On hospice, the hospice is contacted for any emergencies. And on palliative care, the attending physician or the primary care physician is contacted for emergencies, and palliative care is contacted as a supplement. Who would benefit from palliative care? Anyone with a life-limiting illness with symptoms that are unmanaged or a need for advanced care planning or goals of care discussions would benefit from palliative care. And some of the specific disease processes of the patients that we work with, we have a lot of people with heart disease, lung disease, dementia, Parkinson's, stroke. We have some cancer patients. We have some people who have none of those, but are 95 years old and having adult failure to thrive, maybe losing weight, having decline in function, and we also see those people. And as I said, people who would benefit from palliative, anyone with unrelieved symptoms, anyone with a need for psychological, emotional, spiritual support regarding their diagnosis,
Signs of general decline, like I said, weakness, decreased appetite, and weight loss. People who are bouncing back and forth to the hospital, frequent ER visits, frequent hospital stays. Patients who are struggling to make healthcare decisions. And anyone who would benefit from a discussion regarding advanced directives, and that's anyone with a life-limiting illness. Today I'm going to speak specifically about Pathways Palliative Care and our program that we offer. And there's kind of a joke in the palliative care community that if you've seen one palliative care program, you've seen one palliative care program. Palliative care has no regulations that they are bound to follow, which is very different from a hospice agency who has all of these regulations that they have to meet and follow. But palliative care has none. So we kind of tailor our program to our patients' and families' needs and help to be a supplement to our hospice company. So Pathways Palliative Care provides consultative nurse practitioner visits. So as a nurse practitioner for Pathways, I go out and meet with patients and families. Our nurse practitioners meet with patients and families in a consultative role, meaning the primary care physician or another physician, nurse practitioner, such as like oncology or pulmonology. Someone else ordered our service, and they ordered that for a few reasons. They ordered that as a supplement to their care that they're providing, but our piece of the pie is really, our role is to be an expert symptom management provider. So we provide expert symptom management, and we also provide expert advanced care planning services, which means we offer goals of care discussions. That is a huge part of our job and our role. We also provide education regarding current level of disease process. So we help people to understand where they're at in the disease process. Are they early stage? Are they mid stage? Are they late stage and nearing the need for hospice? So we help them understand where they're at in their disease process and help them make a treatment plan accordingly.
And our palliative care visits, the frequency is determined by the needs of the individual patient that we're seeing. Some people we see often based upon their needs, and generally that is a person whose symptoms are unmanaged for a while, so they're having an exacerbation of pain, of shortness of breath, they are losing weight suddenly, and so we're following them a little bit more closely to figure out what an appropriate treatment plan would be for them. And then as those symptoms are resolved, we start to visit a little bit less. And I always explain it to people and their families like it's kind of like a cardiologist. So you might see your cardiologist, your heart doctor, when you're having heart problems. You will probably always have those heart problems, but you're not going to be following up monthly with your cardiologist for years and years and years. You are going to follow up with them during periods of problems, and then they kind of go to the back burner for a while until the problem arises again or there's an acute exacerbation of the illness. And so that's exactly how our visit frequencies are determined. We see people a little bit more during uncontrolled symptoms, and we see them a little bit more if they're having changes in condition, so that we are able to educate them, educate their families, and then assist with making healthcare decisions.
As I said, advanced care planning is one of our major roles in palliative care. And with advanced care planning, the main component of that is to start with a goals of care discussion. And these goals of care discussions, where we sit down with a patient and their family and try to decide what their goals are for their health care, these discussions really reduce patient and family distress because wishes are communicated, they are out in the open. Some patients and families say, I want all the care in the world. I would go to the hospital over and over again if I had to, if it made me better. I would take CPR or I wouldn't take CPR. I want IV fluids. I want dialysis. I want chemotherapy. I would take a G tube, a feeding tube if I needed to. I don't mind being on a ventilator. Some families say, or some patients say, I don't want any of that. I want to, if I have a terminal illness, I want to be kept comfortable. I want quality of life to be the main focus, and I want no aggressive treatment. So it's these types of discussions that lead us to the completion of the official paper documents. So some people want like a do not resuscitate form completed, meaning at time of death, they don't want CPR. Some patients and families want do not hospitalize orders, meaning if they have a sudden change in condition or even a gradual change in condition that results in decreased responsiveness or a significant decline, they would not want to go to the hospital, which is honestly, it's a significant portion of the people that we see at some points in disease processes. And then kind of the final piece of the puzzle to advanced care planning is, does the patient and family want hospice care when the time comes? Sometimes right now, I think about 10, 11% of the people that we admit to palliative care transition right away the same day to hospice care. Sometimes we establish on admission that, you know what, mom or dad is stable right now, but when they decline, when they have a big change, we don't want hospitalization. We want to go straight to hospice. We want to keep mom in the facility. We want to keep mom at home, and transition right to hospice. So those are all types of advanced care planning discussions that we have. And really it all starts with identifying the goals of care.
And part of advanced care planning is discussing treatment options with individuals and their families. As I said earlier, our piece of the puzzle is helping people to be comfortable and helping them make decisions about their care. So as far as treatment options go, sometimes these are what's available is not necessarily what is most appropriate for the individual. As I said on the previous slide, some individuals do not want aggressive treatment, and they don't understand that they don't have to accept that. And so it's our responsibility to educate and inform and empower patients and families to make the most appropriate decisions about their individual care. So some questions that I ask throughout the advanced care planning process. I usually start with asking the individual, what is most important to you? Sometimes people tell me comfort, sometimes they say their family, sometimes it's a combination of both. But either way, that lets me know where they're at as far as feeling like is most important to them at that time. And then I always ask them, if you had to choose between comfort and quality of life versus longevity, which would you choose? Because the answer to this question, these are almost always two different treatment plans. One generally results in more hospitalizations than the other. You know, if you are wanting comfort and quality of life, you might not want to go back and forth to the hospital as you decline. And so really in asking these questions, this helps to direct the conversation and gives it a natural flow.
And I just included a little quote here that I love and I feel like is so, so true. You treat a disease, you win, you lose. You treat a person, I guarantee you'll win no matter what the outcome.
Now that we've talked about the provider aspect of palliative care services, I'm going to move on to support services. So this would include our chaplains, our social workers, our massage therapists, healing touch, and then we'll talk about volunteer a little bit more on the next slide. But so basically our support services are such an integral part of our team. They are our eyes and ears. I receive notifications a few times a week from our support services staff, which we are fortunate enough to be able to utilize our hospice support services team for our palliative care members. But our support services team are our eyes and ears. They are contacting me, letting me know that, I visited with your patient today and she was a little bit more confused than normal. She was a little bit more withdrawn and really notify us of changes in our patients when we might not have otherwise been notified. So they just provide such an amazing support to us, and the support that they provide to their patients and families is just so incredible and so beneficial to them. The socialization aspect, talking with them, just being there, just a calming, comforting presence. And it's such an amazing part of our palliative care. We're so blessed to have them. We appreciate all that they do. So as a hospice volunteer, you might be wondering why you haven't been assigned to see palliative care patients. If your hospice agency that you volunteer for has a palliative care program. And the answer to that question is probably because hospice agencies are actually required. They have to meet a requirement that 5% of the total patient care hours of paid hospice employees is performed by volunteers. And if they don't meet that requirement, they are penalized for that. So in palliative care, as I said earlier, there's really no regulations. So there's not a volunteer requirement to see palliative care patients. Therefore, the hospice patients get assigned volunteers first. Some agencies are able to assign volunteers to palliative care patients, as I referenced a little bit ago. We are able to utilize them on occasion, but hospice patients definitely come first. And really, the other support services are the same way. Chaplains, social workers, the hospice is required to offer that. In palliative care, there's not a requirement, so we do it when we're able. It is our hope in the future in hospice and palliative care that we are able to offer our volunteer services to palliative care patients on a regular basis. And palliative care is an important topic to learn about for volunteers because it's a growing industry. Palliative care really works hand in hand with hospice companies, with hospice, and it's often a stepping stone to hospice. Hospice has only been offered in the United States since the 1970s, and palliative care sort of emerged from this movement. So we appreciate your continued dedication to patient care. whether you're visiting patients or assisting with duties in the office. We also appreciate the opportunity to share more information with you. The settings in which palliative care are provided, right now there are enough palliative care resources in many communities throughout the United States that palliative care is available to continue in between care settings. So you can be receiving palliative care services in your home in the community. You can receive it in a nursing home or assisted living facility, an independent living facility. And if you were to be hospitalized, there are inpatient palliative care programs within hospitals, and generally, like, we are able to communicate with hospitals while our patients are inpatient, and they communicate with us to notify us, hey, your patient's going to be returning back to the nursing home. And so palliative care is really available in any setting that you call home. And I always like to include a couple of real life examples as they pertain to palliative care. So many of the individuals, the patients that we see, have a generalized decline in condition. Sometimes it's dementia related, sometimes it's adult failure to thrive, but regardless, so we are called in to assess a situation, assess a patient, and make recommendations based on their prognosis and their goals of care. I am called in, and a lot of times someone has had a weight loss. They're having falls and declines in their physical abilities. They're having multiple infections. My role is to help the family understand where they're at in the disease process, make recommendations to maybe improve their quality of life, maybe slow weight loss or even stop it, reverse it with like an appetite stimulant. We order therapies to try to restore function if that's the goal of the patient and family. And then we reevaluate that. So if I start someone on an appetite stimulant, then we're going to be monitoring weights and intakes to see if they're improving. And if they don't improve, or when they stop improving and weight starts to decline again, then we go back to the family and make another plan. We've tried the appetite stimulant, we've tried supplementation with Ensure or health shakes, and mom or dad is not responding to that any longer. And now here are our treatment options. We can do a feeding tube, or we can go onto hospice with this amount of decline. And so that's a pretty common situation for us. We also have a lot of individuals that are going back and forth to the hospital. It may be a heart failure person who becomes short of breath, and they feel like they need to go to the emergency room to get that controlled. We can be notified of the change in condition and try to assist with keeping the patient in the facility or keeping them at home in order to prevent that hospitalization. And then also, we help to educate them on when it's maybe not as effective to go back to the hospital. If someone is starting to spend a little bit more time in the hospital than out, we need to go to the family and say, you know what, this really isn't working anymore. Mom keeps having to go in and out of the hospital. She's never quite getting back to baseline. What do you think about this alternative? What do you think about we try one more hospitalization, and if that doesn't work, then we go on to hospice? So that's just applying our palliative care, the everyday work that we do, to real life situations. And all of this is aimed at bringing comfort for the patient and loved ones as long as it's in accordance with their wishes and their personal goals. And another beautiful quote, this one from Hippocrates, that I love to include in my palliative care presentations. And I think this is the goal of all palliative care providers, anyone who works in palliative care or hospice. And the quote is, "To cure sometimes, to relieve often, to comfort always." And that is the goal. That's why we're here. And so to make a palliative care referral, you just need to obtain a physician's order, and that's from primary care or an attending physician or nurse practitioner. Discuss it with the patient and family first, just to make sure they're on board, and then to notify the palliative care agency that they should be receiving an order. Thank you all so much for listening today and taking an interest in learning about palliative care. I hope you have found value in this presentation and hope that you're able to use it going forward in your volunteer services in the community. Thank you so much.